As Dr. Fine told you, I'm Josh Gutman. I practiced up in Attleboro for not quite 100,000 years, 28, and then in the last 12 years, I've been traveling around the country practicing in all kinds of different settings as what they call a locum tenens or temp doc. And I never had a clue as to what you folks did until I got a temp job out of the country in New Zealand. And I was placed in a village of 1,500 people, catchment area of about 2,500. Most of the people worked in farming, ranching actually, mostly dairy farms, and in mining, because they were trying to revive old gold mines and coal mines in the area. And when I got to this little village, never practiced in a place like it before, I was told that it was the doctor's responsibility at any time during the day or night, when the siren went off at the ambulance garage, to run out of the clinic or out of my bed, wherever I happened to be, and get on the ambulance and go with the crew out to whatever they were going to. Now, for a family doctor from Attleboro, this was just, I said, well, you got the wrong guy. I don't know. I had never dealt with trauma. I've never worked in an ER since residency training, and I'm going to be out of my element. They said, don't worry about it, Doc. All we need is somebody to push the morphine. Okay? We take care of the medicine. We just are not licensed to push the morphine. I said, well, I know how to do that. So we would take off in the middle of the night or during the day or whenever anything happened that required an ambulance, and I learned learned to respect greatly what you guys do, because I had, it was just astonishing what these folks did. And basically we would come to whatever the catastrophe was, and if the person was in severe pain and they didn't want to move them, I put the IV in and pushed the morphine, and then you guys did the rest. So it was really eye-opening for me just to have that experience. I don't think enough docs in this country understand or appreciate what you're confronted with. So I wanted to let you know that I at least have a bit of appreciation for that. And I think that it's not at all unreasonable, this whole concept of getting you guys to make decisions in the field about who's a primary care patient and who's an ER patient is a reasonable thing. I think that makes a lot of sense to me, because what I see as a primary care doctor in clinic is a lot of crazy things happening in EDs, not because anybody does it maliciously, but just because the settings are inappropriate and the care is inefficient and expensive when it doesn't need to be for so many people who get to emergency rooms inappropriately. So I think you've all been exposed to that. So what we're supposed to talk about today, what I'm supposed to talk about today is the management of cough and wheezing, and how you discriminate between what needs to be acutely taken care of in an emergency setting and what can be managed in the primary care office. Now, breathing isn't as simple, of course, medically, as we'd like to have it in a single word. So we broke up breathing into respiration and ventilation. Respiration is the chemical process that happens in the alveoli, where oxygen goes across the membrane into the blood vessels, and carbon dioxide comes out of the vessels into the alveoli. Ventilation is a whole separate process, which is a mechanical process of getting the air from the environment into the alveoli and then out again. So we have two different processes, and they are evaluated differently. You have two different ways to assess ventilation and respiration. And it is a little bit important to understand that, and so you know what you're doing when you're making the decisions about who to transport where. We assess ventilation through listening to the lungs. Is the air coming in and out? And when you put a stethoscope on a lung, on a chest, you can hear, is it moving well, is it not moving well? Are there a lot of noises, are there not a lot of noises? The respiration assessment is through putting that pulse ox. Do you guys have pulse oxes on?
Yes.
Okay, so you do pulse oxes, and that's a really simple way to say, is there enough oxygen in the guy, or is there not enough oxygen? And that becomes a very simple way to say, yes, we're going here, or no, we're going there. Extra credit question, that this is all of courtesy of Dr. Fine. One situation in which the oxygen saturation doesn't accurately reflect respiration. Who's got that answer?
Ice emergency? Ice emergency?
Ice emergency. Interesting. You mean if someone who's
drowning,
cold water. I'm not sure. I would think that would suppress ventilation and respiration to the point where you would probably have a low FiO2. I'm not sure. I have to look it up. The classic one that he's talking about is carbon monoxide poisoning. Because that gadget that you stick on the finger doesn't discriminate between oxygen and carboxyhemoglobin. And so you've got this issue of the gadget doesn't understand that there's carbon monoxide in the system. So you have to, if that's a pertinent situation, if you come into a garage and the car's running and a guy's in the front seat, he may not have a low FiO2, but he still has to go to the ED. You don't, because he's got an FiO2 of 98, you don't take him to the health station. So that's just
We have the ability to read that on our SpO2, on our monitor.
Really?
Yeah, we can.
You can discriminate
We can read the carbon monoxide level.
Excellent. Super. Now, cough makes people feel bad and makes them call you guys.
Did I just ruin that? That call's going to be ruined in a week. Sorry.
Cough makes people feel bad because it interrupts sleep. It transmits infectious diseases. It's sometimes indicates heart failure. Can be a presenting symptom of other lung conditions, and it can also indicate someone has asthma. But most cough is benign and will go away by itself in a few days and can be treated very simply, and is usually a symptom that is quite readily manageable in the health station as opposed to the ED. Feel free to interrupt, throw questions whenever you want. Cough is common. It's one of the most common symptoms seen by primary care doctors, and so most of the guys in the health center see this every day and are comfortable managing it. Most acute cough is associated with viral upper respiratory infections, which last 7-10 days or less, or with seasonal allergies. So it's quite common with both of those, and both of those are very simple issues. And your job, it's another slide, is picking out the needle from the haystack of common conditions that go to the health station versus those very unusual situations where you need to take them to the ED. So how do we think about cough? Well, we ask about how long it's been there, duration, the quality of the cough. Is a lot of stuff coming up? Is it not no stuff coming up? Is it associated with things that are more dangerous than a simple cold? We want to know if it's associated with difficulty breathing, wheezing, or new swelling. And is it connected with smoking? We want to also ask about triggers. Is there something, do they have a fever? Were they exposed to stuff that makes them cough? And are there other symptoms as we listed above there? And we want to know, obviously, if we can check and see if they have a fever. What we're trying to what we're trying to assess and determine whether they need to go to the health station or the ED is how much is there some danger associated with this cough that could lead to an immediate problem? Could there be a bacterial infection? And is this just a cough, or is it associated with the wheezing component, which has additional possible risks? And the key thing is, could this be heart failure? That's the real elephant in the room. Is if somebody's coughing and they may have heart failure, that's an emergency department visit. And do you have to? This is a much less common concern because cough is so common and these things are relatively uncommon. Could they have lung cancer or some kind of intrinsic lung disease that needs to be evaluated in the ED? And at the bottom you note that this is the needle in the haystack problem. Is 1 in 100 of these cough cases are going to be severe enough to need to go somewhere more intensive than the health station, but you like to be able to sort those out. And once again, the advent of pulse ox, I trained and practiced for the first half of my career with no pulse ox. I mean, it's just amazing the difference that came when we got that number, because up till then it was the basic eyeball issue. When I trained, back just after the flood, Noah's flood, we were taught as medical students and interns that your basic problem, and it's your basic problem, is distinguishing between sick and not sick. And it was just hundreds of cases. An internship involved 120 nights in the hospital, getting 8 to 20 admissions and seeing a new patient every half hour and admitting them to the hospital and figuring out, is this the one I have to spend the time with, or is that the one I have to spend the time with? Can I park this one and just write a bunch of orders and off they go till the morning? Or is this going to crash and I need to have the ICU guy or the surgeon or somebody else get in here and look? You guys get that because you probably walk into a room and pretty quickly now say, this one's sick, this one's not sick. And this thing has been a tremendous help with that, because assessing someone's ventilatory function, or I should be precise, respiratory function, which is what the O2 sat does, is pretty, it's more a matter of feel sometimes. I mean, you get respiratory rate will help you, pulse will help you. Are they blue? I mean, you can often eyeball it and say this one's bad and this one's not, but putting that O2 sat just sort of takes care of the problem. If they're greater than 97%, we should think about taking them to the health station, because that's probably not something that's going to be a immediate problem that needs emergency room equipment. If they're less than 90%, and I think your guideline is less than 92%, we don't have to call anybody. We know where they go. They go to the emergency department. In between 90 and 60%, 90 and 96%, that's the gray area where we need to do some thinking here. Most of these people, or many of these people, if they're not known to have lung disease, are going to be people that you want to take to the ED. On the other hand, you will get to know the chronic lungers and the asthmatics, who will often show up. They may walk around every day with a SAT of 94 or 95, and if they're still 94 or 95, they probably can go to the health station to be evaluated. So it's if you make the call to the health station and the guy can pull up the record and say, oh yeah, he's always 95%, we'll take him. That's easy for you. So I think that's where the break point is, and where you have to have it becomes a judgment call. And what did they tell you about judgment calls? If you're worried, go to the ED. And most of the asthmatics who are in that mid-range can be handled in the office with nebulized albuterol, and we talked about the bottom one. Wheezing, you all know that noise. You've heard that noise enough, so it's not confusing. And that's the ventilation problem, where there's spasm of the breathing tubes that causes the noise. We call it bronchospasm, and one of the crucial points here is that everything that wheezes isn't asthma, although usually it is, and not all asthma wheezes. You get these people who are so either fatigued or so constricted that they're just hardly breathing, and you don't hear any wheezes when you listen to them. Now, most of these people are going to have big-time drops in their sats, so they won't be confusing to you, or they'll be blue, or they're going to look sick. And when they look sick, if they are asthmatic, they go to the ED. What are the things that wheeze that are not asthma? Well, the big one is heart failure. Now, your 17-year-old who's wheezing is probably not going to have heart failure unless they have a history of congenital heart disease, and those people are rare and few and far between, but something to, it's always something that you want to keep in the back of your mind with somebody who's wheezing. Could that be heart failure? If they're not swollen, if they don't have a history of heart disease, probably it's asthma. The constricting masses in the lung can cause wheezing, very unusual, almost not a serious consideration. Foreign body aspiration in little kids, that's always a consideration. And then the other thing that you hear in kids is croup noises, and those things it almost sounds like wheezing, but it's different. And it's often hard to sort that out. Sometimes, if you're very adept with a stethoscope and you can hear that the lung sounds are actually okay, that the noises are coming from the large airways. The difference between croup and asthma is that the noises that are coming in asthma are coming from the small airways, the distal airways near the alveoli. The noises that are coming from croup are coming from the large airways, and so it's a different sound. Probably it becomes what they look like, what their vital signs are, and what their O2 sat is, how you make that discrimination as to where they go. How do we think about wheezing? Well, is there respiration, that oxygen exchange, so compromised that they need the ED, and that's usually assessed by the O2 sat? Is there a reason to think this is anything other than asthma? And that we assess with history of fever or measurement of fever, and if they're producing a lot of phlegm, what does it look like? Are they are they coughing up blood, or are they coughing up lots of pus? Are they people with known history? If they've got asthma and they're wheezing, they're probably having an asthma exacerbation. If they've never had asthma and now they're wheezing, maybe we need to be more cautious about that one. Maybe that's a ED visit. Do they smoke? They smoke. They have a propensity to wheeze because they have a greater propensity to have COPD, and COPD can cause all the same symptoms as asthma. And the last thing is, obviously, if they have asthma and you think, well, we can take care of asthma in the primary care setting, which we all think we can, but they have signs that they're really starting to develop respiratory failure in terms of their pulse is really high, their respiratory rate is really high, they're tugging, you can see the tugging in there between their ribs and over their clavicles, then maybe that's a guy that needs to go, even if their O2 sat hasn't started to drop yet. Now, we've said this before, we can treat asthma in the office if they don't have a high fever, if they're not dehydrated, if they don't have other stuff that's causing the decompensation, or if they're so fatigued that they're going to need to be intubated. We use the albuterol nebulizers to treat, and it almost always works. And then we give them prednisone to treat the inflammation. If it doesn't break with 1 or 2 treatments, we ask you guys to take them to the ED. I think one of the things I was talking to Dr. Fine about was that concern that you assess them in the field and you say, well, it looks like an asthma attack. We could probably get that treated in the health station. They come to the health station. We give them a couple of neb treatments. They don't get better, or they start getting worse. We call you guys back and you got to do it again. And I think that's the kind of thing that we're trying to figure out how to sharpen that assessment to the point where that decision could be made in the field and we minimize the mistakes. I don't think it's terrible if 1 out of 50 or 1 out of 60 or 1 out of 100 come to us and then go to the ED because they're a failure. Because that's what's happening now. The asthmatics who come into our office, most of them, and I don't know what the percentage is because I don't have those numbers, but it seems to me that 80 or 90% of them get better, you send them home on prednisone, everything's fine. But there's a certain percentage of them that we call you guys to take in. You know that, you've been there.
Do you have a form of triage in your facility so that you can treat these more urgent cases versus a waiting list of who walk through the door, or how does that work?
Yeah, if somebody walks in and says, I'm wheezing, I'm having trouble breathing, that's get them in
Front of the list.
put them on the front, yeah. You don't make them wait for the routine visits, that's right.
So the likelihood of
It's like chest pain. Shortness of breath is like chest pain. That's a ticket to get in a room.
So you have that ability to
Oh, yeah.
shuffle those.
Oh, yeah. Yep. And, it's interesting because my experience, as I say, I've been in 25, 30 different places around the country, and different places are so different in the way they manage this. Some places, you hear the front office person, that gatekeeper at the front desk, hears chest pain and shortness of breath, and they are in a room. There's no interference. In many places, that's the signal to call the nurse and have the nurse do an initial triage. So different places have different ways of doing that, but most places have those 2 items, chest pain and shortness of breath, are triggers of let's get something done quicker rather than wait for the routine. And the thing that I can't emphasize enough is the difference between the ED and the health station and the primary care doctor's office is this last thing, is the follow-up. The reason that ED care is inefficient and expensive is because it's a one-shot deal. That ED doc knows I've got to get everything taken care of now. And the primary care doctor has a whole different mentality about primary care problems, non-emergency problems. We understand that we do an initial assessment, we develop a hypothesis, which is called differential diagnosis, and we start with the most common or the most likely thing, and we give them a trial of treatment and see them back in a certain period of time to assess the progress. And we give them a list of things to worry about. If this goes wrong or that goes wrong, go to the ED or call me. So we have this sort of a long distance approach, whereas the ED guy has this 10-minute approach. I've got to figure this out, treat it, get them out the door, or admit them. And that results in a lot more being done that might not really be necessary if you had this primary care view. And so our view results in what I think is more efficient and less expensive care. And it's just because of the perspective of the ED doc versus the primary care doc. So this is the whole summary of what we talked about. The symptoms are very common. The oxygen sat is the simplest and quickest way to determine where to move people. And most of us manage the wheezing fine and cough in the primary care setting as long as the sat is less than 97%. Questions? Got through this in half the time I was supposed to. So we got cases on cough, and I chopped up the cases because there were cases that I like to deal with and cases that I wasn't sure what to do with. So I have them in a little bit different order than you have them, and we're going to get them up on the screen, I think. Oh, look at that. Can I do that, or the bottom one? Yeah, that's the one. Beautiful. Oh, I love it, love it. So this is this the same case that you've got in your?
It's a little small. I can't read that.
Can't read that. It says a 20-year-old complaining of cough since the weather turned cool.
Yep, that's what we got.
All right, somebody want to read that? And somebody start reading anywhere if you want.
A 20-year-old complaining of cough since the weather turned cool. She's been coughing for 6 days and the cough is keeping her from sleeping. Sitting at the kitchen table when you arrive, well-appearing, Hispanic female with watery eyes, speaking in full sentences, able to laugh and joke with you. Temperature of 98.2, blood pressure of 110/60, pulse of 68, oxygen saturation of 99%. Clear lungs, heart regular rate and rhythm, extremities without edema. She's a Blackstone Valley patient, but had to wait for 6 minutes on the phone when she called, so she hung up and called 911.
Okay, there you go. Seen that before?
Oh, yeah.
Oh, yeah. And so the question number one is, what's the most likely cause?
Cold. Seasonal cold.
There you go. Cough, seasonal allergies. Since the weather's turned cool, does that mean like fall allergy, maybe some ragweed, possible, or just a viral URI? What are the other possible? What do you worry about? I mean, this is so simple, and you say, well, she's not sick, right? You look at this lady, and that's I think the point. She's able to laugh and joke with you, speak in full sentences, vital signs are good. So this is not sick. And you say, well, I'm going to take this over. I'm going to take this over to the health station. What would go through your mind and say, maybe not?
The length of the cough? The length she's had it, maybe?
The length of time.
What's the cough producing?
6 days.
What's producing?
Could be an allergy, last a long time. Could be a cold, last 7 to 10 days, maybe. Asthma. She's clear lungs and a good sat, though. If she had asthma. So this lady now tells you, well, I got asthma and I occasionally have to use my pump. And you say, does that deter you from taking her to the health station? No. Because?
She was ready to go there anyway. She was just too impatient to wait for the appointment.
That's one. Sat more than 97. Vital signs.
Stable.
Yeah, stable. Excellent. Okay. So the things that we might worry about, asthma or postnasal drip or early pneumonia. Could this woman be developing pneumonia? Possible. But I wouldn't take her to the ED because of that, because I think that could be assessed in at the health station. How will you treat this woman? Do you care? I was surprised. Michael did these cases. I was surprised he put treatment on the list. Do you?
Well, we're not gonna treat her.
You're not gonna treat her. Yeah, I mean, in the.
Give her a ride for you.
That's right, you treat her with a ride, that's right. This is, in the office, this is going to be managed with what everybody calls symptomatic treatment, right? You're going to use some decongestant maybe, some Sudafed. Or if you think it's an allergy, if she has a history of allergies, she's got the watery eyes, you might, an antihistamine, some, what's the antihistamine? Antihistamine of choice. We don't use Benadryl as much in primary care now because of the sedation. We tend to go with the non-sedating antihistamines, Zyrtec and the other couple, those kind of things, just because we're trying not to put people to sleep and let her go back to work or take care of her kids. So we got decongestants, antihistamines, fluids, rest. For the cough, you can use a cough suppressant, dextromethorphan, DMs. How long will it take for treatment to be effective? What's our crystal ball say? Yeah, a day or two. What changes will the doctor warn her to watch out for and tell her about calling back or coming to the ED? That's the kind of stuff that we're talking to you about to watch out for, is take them to the ED. What do we say to her? High fever.
Blood in the rash.
Bad sputum. If you start coughing up blood or lots of pus, that's good. And the third thing on my list was shortness of breath. You have trouble breathing, now you got to think about getting over these. So the second one, which is your number 3.
That bottom, right of the screen up there, see that bar?
Oh, yeah.
Make that, finish him out.
I need that guy.
Definitely Japanese.
Yeah, yeah, you need that. Yeah, there you go. There you go. No, 2. There's one above it. There you go. Do you have that, I think it's number 3 on yours, the 47-year-old asthmatic smoker. Somebody want to read that one?
47-year-old male, Hispanic, asthmatic smoker with a cough. He's had a non-productive cough for 2 weeks, worse at night. He's not short of breath but feels congested. He smokes 1 pack per day and is trying to quit. He called 911 because he ran out of his inhaler, which is the medicine he uses to control his asthma, and that worries him, even though his inhaler isn't working to stop the cough anyway. Temp 98.4, 130 over 90, pulse 92, O2 95%. 1 lung examination, and he's moving air well without wheezing.
Yeah, that should have been on lung examination, I guess. I missed that typo. So the question is this asthma?
Quit smoking.
Yeah.
Oh, well, yeah, for sure. That's the next question, right. But if you had to guess as to whether this guy has, well, asthma, I'm thinking about bronchospasm. Do you think his cough is being caused by problems with his alveoli, respiration, or problems in his breathing tubes, ventilation? Hard to know. If we took a vote, we might get 50-50. Some people think he's got asthma, some people think he's got some other disease going on in there. Why would you, what would lead you to go more with a bronchospasm problem than a alveolar problem?
Worse at night laying down.
Worse at night laying down. Often asthmatics will tell you that. That's right. Their asthma gets worse at night.
He ran out of his inhaler.
ran out of his inhaler, even though he says it wasn't helping him. And the other thing is non-productive cough, right? He's not coughing up a whole bunch of stuff. So that sort of slides me over to the bronchospasm type, even though I don't hear wheezing. Where's this guy going? What are you going to do with this guy? ED. No argument anywhere. All right. See, I wouldn't feel bad if you took him to see me over at Blackstone Valley. He might be worth a call because he's a smoker. He may be living in 95, 96 territory all the time, and having his record would be handy. So this guy might be worth a phone call. Nobody's going to argue with you if you take him to the ED, that's for sure. But I think sometimes these cases can be useful as at least put it into your mind that, maybe if he's got a doc over it, and I guess that's the criteria that, if he's a patient already at the health station, getting up his records and finding out if he shows up like this every 2 months and you've never seen him before, maybe somebody else has, but if he shows up with this kind of thing all the time and takes a couple of respiratory treatments, it's going to be a much more efficient, cost-effective management if he goes to the health station. So at least it's a coin flip, maybe, with this guy. What's the major immediate risk to his health? Okay, excellent. This is a primary care answer. I love that. Okay, what's the smoking? Right? Most immediate risk to his health. Now that's not an ED answer. What's the ED answer? What's the biggest risk to this guy? He's going to decompensate and go into respiratory failure and need to be intubated. Right? So the answer to that question depends on long perspective, short perspective. Again, ED perspective, primary care perspective. We're trying to turn you guys into primary care EMTs instead of emergency room EMTs. Now that you can't do that. It's not right because you're dealing with real ED stuff. But the effort, I think, is the way I understand the program, is to at least have half of you looking at things from a primary care perspective. Then I got number 3. Number 3 is your number 4. Somebody read that one. 68-year-old female call 911.
68-year-old female who called 911 because she is short of breath. She stopped smoking 15 years ago, but has AODM. Is that?
It's onset diabetes mellitus.
HTN and CADs, CAB times 3 20 years ago, and CHF. She's on 11 medicines. She went to a family dinner last night and then got progressively short of breath overnight. Temperature's 98, BP's 150 over 96, pulse is 110. O2 stats 88%. She's wheezing bilaterally and has 3 pitting edema.
What is the?
Can we go over the abbreviations?
Abbreviations, fabulous. I was that was one of my frustrations with the cases, and I didn't go through the hassle of writing them out, which I should have. Adult onset diabetes mellitus, or type 2 diabetes. You're going to see that abbreviation on records if you look at records all the time. HTN is hypertension. CAD is coronary artery disease. CAB, never use that abbreviation myself. What's CAB? Coronary artery bypass. Might be single, might be double, might be triple, quadruple. We don't know how many. Well, yeah, we do, because it's times 3. We know it's a triple bypass, yep. And it's a long time ago, somebody who has had CAD since age 48 and CHF. So that's the abbreviations. Is this asthma?
No.
No. What is it? Congestive heart failure. Yep. And you guys would recognize that right away. You wouldn't. This wouldn't fool you. at all. If you got the history, I mean, if she just called in that she's short of breath and wheezing, and you got there and she was wheezing, unless you collected the rest of the history, you might be able to mistake that. What's the relevance of this history after the 11 medicines? She went to a family dinner last night.
Salt.
Yes, exactly. We see this, the emergency room was waiting for the heart failures coming in, the pulmonary edemas coming in, night after Thanksgiving, night after Christmas. Anytime that people were going to overindulge, you were going to see a big spike in the pulmonary edemas coming in. What's the right treatment for her wheezing? Lasix. Nice. Diuretic, some kind of diuretic. And Dr. Fine's question at the bottom of this is really sort of an interesting one philosophically. Why don't we see this so much anymore? We used to see this every day in the emergency room when I was a trainee, and we don't see it nearly as much anymore. Anybody have a theory of that? I don't know if you noticed that over the course of your time, anybody who's been doing this for more than 8-10 years, do you think that are you seeing less of this in the field? Not clear. Because it's definitely less. We see less people coming back to us in primary care from ER visits for pulmonary edema. No idea why.
Prescribing better medicines for diuretics?
It's not just the diuretics, that the treatment of heart failure is dramatically improved because of the addition to diuretics of ACE inhibitors, or ARBs. ACE inhibitors are angiotensin receptor blockers, and beta blockers, but also because of the better treatment for coronary artery disease. When I trained, the treatment for heart attacks was three weeks in the hospital. I mean, even then, I'm not sure if we were giving them aspirin. I mean, it was just, you let them scar and get better, and that's what happened. And now, they're getting immediate cath and stents, and so people are developing less chronic disease from coronary artery disease than they used to. And so you don't see quite as much of this as we used to. The next one. How about number 4 is, I don't know which one that is.
Number 6.
6, okay. Number 6.
8-year-old with a cold, 3 weeks, runny nose, a little night cough, low-grade fever, but no thermometer at home. Child is eating and acting okay. Mother called 911 because she was getting ready for work. Because she has no car, she lost the number for Blackstone Valley. Temperature 99.2, blood pressure 92, 54, pulse 104, sat at 99%.
So we got now a kid. You get called for a lot of kids? Oh, yeah. So would you, when you took a look at this kid, basically with the information you have, is this a bacterial or a viral illness? More likely.
Bacterial.
And why would you?
3 weeks. 3 weeks.
The prolonged one. Okay, fair enough. And then, and so what would you likely do with this 8-year-old?
Straight to the ED.
ER. So I got a couple of ERs, I got a couple that come to me.
Less than a month, so. Oh, I'm sorry.
Mom should call the pediatrician.
Yeah, well, Mom should have, yeah, she lost the number. The pediatrician or the family doctor at the health station would be very happy to see this kid, in spite of the length of illness, which I think is a pertinent thing for you to look at. I think that is a concern. The trouble with kids is they get them and they get them and they get them. They're in school, Mom says this has been going on for 3 weeks. What really happened was, she had it for a week, she got better, she went to school, she got another one, and they just keep coming up with one virus after another. Could be bacterial, temperature's not high, the vital signs are good, the SAT's good. So we would all be comfortable, if you're comfortable, when you take a look at this kid. If the kid, one of the things that, eating and acting okay is I think the other key, as well as the stability of the vital signs, is the kid's eating and acting okay, we're happy to take that call from you and say, yeah, bring that kid over to us in primary care. So I want you, that's another situation where, in spite of the concern about the duration of the illness, which is important to look at, the rest of the story is not looking sick. Again, sick, not sick. If she's not sick, we'll see her. What's the likely treatment? Same as the first one, right? Symptomatic, let's try to cut down the congestion if we can find a way to do that. Let's try to make the kid feel a little more comfortable. Let's give him a lot of fluids, and hopefully that'll get better. And we also tell the mom what to look out for if things are going downhill. Because we don't have to cure this at the initial visit. I think the next one is number 9, is it? Yeah, I got number 9. That line up with this one, number 9, 68-year-old house cleaner. Read that one. Number 9.
68-year-old house cleaner with fever, muscle aches all over, headache, sore throat, yesterday, but a little better today, nausea and some vomiting. Her husband called 911 because she couldn't get out of bed, but is responsive to questions, can sit and walk, but is sitting at the table with her head in her hands when you arrive. It's late February. Clear lungs, temperature 102.6, pulse 104, blood pressure 126/68, and oxygen sat at 98%.
Is this a bacterial or viral illness? Got a viral. Bacterial? Pneumonia. So we got maybe. And certainly the height of the fever might indicate a bacterial illness. Her blood pressure's okay, she's not hypotensive, her oxygen sat's okay. And they don't tell us about a cough, unfortunately. So that's an issue of, is this really a respiratory illness? Or does this belong to our next segment of nausea, vomiting, illness? What else, when you say viral, what virus are you thinking about?
Flu.
That's right. It's late February, high flu season, all right? So the question is now, what do you do with this lady?
Put a mask on her, avoid her. Put a mask on her, avoid her.
Avoid, yeah, that's right. Good.
Try not to get it.
Well, take your flu shot but in October. Would everybody pretty much comfortable with moving this lady to the ED?
Because of her age.
Because of her age and her fever. I think that's a reasonable trip. We see these people all the time in primary care. So it's sort of, that's a negotiable discussion, but nobody's going to argue with going to the ED for this. But you need to know that we take care of these people in primary care. How do you treat them?
Fluids.
Fluids. Zofran for the vomiting, good. Any treatment for flu? There is Tamiflu, right? There's that antiviral now that people are using a lot of. If they're seen within 48 hours of the onset of illness, Tamiflu will shorten the illness. So the symptomatic treatments that you all talked about are perfect. And there's not a lot that the emergency room is going to do for this lady other than a rapid flu, which we do in the clinic now. I mean, the health station has rapid flu testing, and once the rapid flu testing comes back positive, you're pretty much free and clear as long as the patient knows what problems to go to the ED for. So we talked about treatment. What might happen without treatment? What happens to flu patients usually?
Could get worse.
Not usually.
Might get better.
Usually gets
It's not
better,
get
but
worse, get
when they
better.
get worse, what happens? What happens when they get worse? Pneumonia. A super infection, we call it. The bacteria takes advantage of the situation of reduced immunity and jumps in and kills these people occasionally. How likely is it? Not likely. How soon should treatment be started?
Right away.
Right away. Good. Did I do another one? What's the next? Oh yeah, here she is again. 68-year-old house. The next one, right? 10? She has a cough. Tell me about the 68-year-old, this other 68-year-old is complaining. Next week, a month later, she calls you back to come again.
A week means lung cancer. It's August, dry rail over most of the right face and mid lung fields.
No, I got the wrong one.
Number 10.
Number 10.
I'm sorry, I'm waiting. I'm at the last page.
I like your style.
Sorry.
Anybody got this one? The one with the racking productive cough.
What's a racking cough?
That racking is that cough where their whole body
Yeah.
shakes with it.
68-year-old house cleaner with racking productive cough, fever, and fatigue. She has been sick for 7 days and had muscle aches all over, headache, nausea, vomiting, and sore throat initially. The sore throat, nausea, and vomiting got better, but the headache remains. The muscle aches are a little better, but still present, but the cough just won't stop. Her husband called 911 because of the coughing. It's early March. Crepitant rales at the base of the lungs, temp 102.6, 110 for a rate 126 over 68, satin at 92%.
Is this bacterial or viral? Bacterial. No arguments about that, right? What else? What else could it be? I guess you could argue if this lady had, which there's no history of here, if this lady was a 50-pack year smoker and had a history, the long-term smoking history and COPD, this could be just a decompensation of her COPD with the flu. Always possible. I mean, it could be a viral process, but you're 98% right here. This is bacterial, given the information presented. What's the likely treatment? Antibiotics. Yeah, you gotta give this lady antibiotics. What might happen without treatment? Same thing we said with the other lady, except in that case, it was very unlikely that she was going to get sicker. In this case, it's much more likely that she gets sicker. And how soon should treatment be started? Right away.
Right now, because her husband can't sleep at night because he's coughing. Something's gotta be done.
So now, can you guys give me cases or give us cases that you think are more useful than these in terms of assessing a a respiratory patient where you've got to make the decision to the health station or to the ED. Something that you've seen in the last little while.
We had, she was like 92-year-old female. She had called and she had fallen. When we arrived, she was face down, she was weak, and she had vomited. When we rolled her over, she had a very productive, like, wheeze, almost rail-like. And she had a history of CHF, and then when we got her in the truck, she had, I clearly wouldn't have gone to the health, I'm just curious about it, she had new onset AFib for us.
There was no doubt about that decision, sure.
Yeah, but she only complained of weakness when we got to her, and that was the reason that she fell. But she never had that productive wheeze, where it sounded like a COPD wheeze almost, really gargly when she would try to talk. Then she had a non-productive but productive sounding cough. It was just kind of, it was a weird combination of symptoms.
Well, a lot of what you're describing tilts you way over to the likelihood of congestive heart failure, right? The productive stuff is more COPD, asthma, or pneumonia. The non-productive with a wheeze is that, oh, this is a wheeze, but it's not a respiratory kind of wheeze. It's not a breathing disease wheeze. It's a different kind of a wheeze because it's associated with it's different, and so that triggers you off in thinking about heart failure, and the AFib. That's the cherry on top that says, okay, now we know what that is. Good. No, those are important factors to all consider. We didn't put all these factors in, but somebody who's gone from a normal rhythm now to an abnormal rhythm, okay, now we're thinking heart rather than lungs. Another case, something that disturbs you when you see people with breathing problems. Other questions, other issues that you want to bring up, or we'll take a break and go to nausea, vomiting next? Fair enough. Let's do 10:15.